Can you explain how the payment system works in the NHS, and why does the payment system matter?
The payment system for hospitals is based on a simple principle of equal pay for equal work. So the more patients that a hospital treats, the more money that it receives. And that matters because hospitals ought to be rewarded for the activity that they undertake.
And this payment system is called payment by results. What are the lessons from the payment by results system?
Well, the main lessons are that by being rewarded for the amount of patients they treat, hospitals have had a strong incentive to treat more patients. And what we've seen since that payment regime has been introduced is that hospitals have done more work, treated more patients, particularly elective patients. And that has complemented the waiting time policy, whereby waiting times have reduced. So more elective patients are being treated and waiting times have gone down. We haven't, though, seen wide-scale substitution of hospital care for care delivered in the primary or community care settings, which was another policy ambition. And the reason for that is that primary care trusts, who have been the commissioning organisations, have not had the mechanisms or ability to restrict GP referrals and reduce hospital admissions.
The NHS is being reformed and faces an unprecedented financial challenge. How does the payment system need to change to reflect the challenge of reform and the need for greater efficiency?
Hospitals under the current payment by results arrangements face very strong incentives to treat ever more patients. It's desirable that they face those incentives, but they need to be moderated so that the system doesn't become unaffordable. At the moment, the pricing system has too strong an incentives to treat more patients, and we need to keep paying hospitals according to the work they do, but to have a system of volume control in place that means that we are living within our means. GP consortia, who are going to be introduced, probably aren't going to be strong enough to resist the incentives for hospitals to do more work. So other organisations such as Monitor and the Commissioning Board need to play a strong role in both setting prices and monitoring hospital activity.
Monitor is being given responsibility in the new system to lead price setting. How would you judge whether Monitor has been a success?
I think there are three things to look at. One is the level of expenditure in the healthcare system. The other is where patients are being treated. And the third is whether quality improves. So on the first, we need to ensure that the system is affordable and that we retain expenditure control both in the hospital sector and in the wider NHS. On the second, we need to ensure that the patients who need to be treated in hospital are being treated in hospital, and those for whom care is better delivered in the primary or community care settings are receiving services appropriately in those settings. And thirdly, payment by results up to now has basically been payment by activity, and the result has been being treated. What we need to introduce are mechanisms to ensure that the quality of care is improving over time as well, and reform is being introduced in that basis, so that the Department of Health is introducing what are called best practice tariffs, which means that the payment that a hospital receives is not just based on whether a patient is treated or not, but the quality of care that they are receiving. And Monitor needs to ensure that we are monitoring, as implies by their name, the quality of care in the health service, and that hospitals and other health service providers are being rewarded on the basis of their quality, not merely their activity.